Good morning. So I'm going to be speaking on the impact of a new surgical instrument on topography-guided LASIK outcomes. So I have designed this very simple globe stabilizing instrument that you can see, which I use for LASIK. So it's got a head and it's got a handle. So the head basically has multiple blunt teeth to hold the eye still during ablation. And there is a flap hinge, LASIK flap hinge protector on top, which helps to protect the retracted flap during surgery. Okay, so we wanted to test out how the instrument works. So we did a retrospective analysis, which was a single center study where all eyes undergoing Contura femto LASIK over a period of 8 months were included. And we included all patients with myopia, myopic astigmatism less than 8 diopter spherical equivalent. Exclusion criteria were coexisting pathologies, extreme ages, BCVA worse than 6/9, patients not completing follow-up, and any flap-related complication. So after we reviewed our data, we found 210 eyes of 105 patients that were fit for the study, and there were two groups here. Group A was the control group where we did not use any instrument. That included 100 eyes done by a specific surgeon. And Group B was the study group, which included 110 eyes where the instrument was used during ablation. So we did a normal preoperative assessment of corrected distance visual acuity, refraction, contrast sensitivity using spatial frequencies, corneal aberrations using Scansys anterior segment analyzer and Topolizer Vario. Surgical technique was very standard for all the patients, Contura topography guided LASIK. The flap was done with a Zimmer femto machine, superior hinge, 90 microns, 9 millimeter flap diameter, ablation zone of 6.5 millimeter, and standard protocols of surgery. All the post-op assessments were done at 3 months with uncorrected distance, manifest refraction, corrected distance visual acuity, contrast, and corneal aberrations. Analysis was done using MedCalc calculator for statistics, and the standard refractive 9 graphs were used for reporting. If we look at the results, both the groups were matched well in age, gender, spherical equivalent, sphere, cylinder, and type of cylinder. So there were no differences statistically between these two groups. If we look at the primary outcome measure, the uncorrected distance visual acuity was significantly better in the study group where we used the globe stabilizer. The post-op spherical equivalent was not statistically significant, but the post-op residual cylinder was significantly lower in the group where we used the instrument. If we look at the refractive graphs, again we can see more percentage of eyes with better vision, 20/16, and more percentage of eyes with one or more lines of improvement in acuity, again in the group where we use the instrument. Efficacy index was also better. These are the spherical equivalent charts. These were not significant. But again, if we look at astigmatism accuracy, more percentage of eyes were within 0.25 diopter of residual cylinder. So 100% eyes were within 0.25 versus 75% where we didn't use the instrument. Now coming to a very important parameter, the higher order aberrations. So the induced total higher order aberrations, vertical coma and horizontal coma, all were significantly lower in the group where the instrument was used. Only spherical aberration was the same between the two groups. And this graphically shows the higher order aberrations. So whatever is in red is where the instrument was used. You can see all are lower. You can see the dotted horizontal line, which is the 0. So anything below the 0 is actually improving the aberration. So vertical coma significantly improved post-surgery in the group of patients where we use the instrument. We also did a linear regression analysis for both groups individually to compare the main outcome measures with some preoperative parameters. And what we found in the group where we did not use the instrument, both the post-operative uncorrected vision and the higher order aberrations were significantly correlated with the pre-op spherical equivalent. So if we look at the graph, we can see in the group where we have not used the instrument, per diopter increase in myopic spherical equivalent, the higher order aberrations increased by 0.04 RMS. But when we did it for the group with the instrument, we saw that there was no such pattern. So this tells us that when we use the instrument, even in higher refractive errors, we are actually not inducing more aberrations as compared to not using this instrument. So just to conclude, by using a simple globe stabilizer instrument while ablation, we are significantly improving refractive accuracy and efficacy. We are inducing lesser aberrations. In some cases like vertical coma, we are actually improving the vertical coma from pre-op. And The induced aberrations increase for higher refractive errors. That also we have established when we are doing topography guided LASIK. But when we use a globe stabilizer, we are actually negating this effect. So in conclusion, we found that when we use the globe fixation instrument, we are improving our visual outcomes, and this is more so seen in higher degrees of ametropia. Thank you.
Interesting. When you put this globe stabilizer, does it need any kind of anesthetic drops?
No, ma'am. It's
How are you going to place it then? It will not hurt the patient?
no. So the teeth which are there are blunt. They are blunt enough not to hurt the patient, but at the same time they hold the eye very still during ablation.
Practically, we may use some paracaine or something like that.
So,
So
ma'am,
that adds on to a little bit.
we have not noticed any discomfort the patient has felt while using it.
Okay. And what about the iris tracker? That is already there.
So yeah,
along
the
with,
iris tracker
it's
is there,
over and
and
above.
it is we have extensively tested it that it doesn't affect the iris tracking at all. So the iris tracker, because it is a steel, it is not affecting with the iris
So
tracking.
it's a double protection for
Yes.
an anxious patient.
Yes.
And of course, a central
So
ablation.
anxious patients and patients where the ablation is going on for longer time, it works really well because we are holding the eye still at that time.
And doesn't affect the ablation pattern.
It doesn't. It will only prevent ablation on the hinge if there is against the rule astigmatism. So that may affect it in some way, but it would be better than if the ablation would happen on the undersurface of the hinge.
Right.
Yeah, but to protect the, I think basically if you're not using, it seems unlikely you can use this without any anesthesia drops. And when you are using, basically what the design you have shown is, basically it is just protecting the hinge.
Yes.
And the tracker role is also very significant with the high-end machines, and you are negativating that.
No, no, ma'am.
So-
The tracker is working. What
Yeah.
happens is that if the patient moves, the tracker moves with the patient. But
Yes.
only thing is there's a small latency in the movement of tracker. So here, what we are trying to prove is that in spite of having a tracker, we are trying to make sure that the laser is fixated in the center and the patient is not moving.
Thank you.
Thank you.
So I think this instrument might have use in patients who have nystagmus specifically because those eyes it's very difficult. Sometimes the tracker even doesn't work, so probably the tracker would work better in this case.
True.
Maybe we need a multi-center study to really evaluate the tool better and to be able to understand how.
It's available commercially with Epsilon, so it can be tried.